Hello, my name is Dr. Payal Kohli. I'm a non-invasive and preventive cardiologist, founder and medical director of Cherry Creek Heart, and assistant clinical professor of medicine at University of Colorado Anschutz. And today we're discussing heart failure prevention strategies, what you can do and how you can educate your patients. And today I want to talk about prevention in a way that we don't normally think about. We are so good at thinking about atherosclerotic cardiovascular disease prevention, but heart failure prevention has become a new focus scientifically. And as a preventive cardiologist, I'm thrilled to see this change because many of the principles from atherosclerotic cardiovascular disease prevention we could very easily apply to heart failure prevention as well. So if you think about what has happened in medicine over the last several decades, it's really been a shift in our philosophy to start to identify patients earlier and earlier in their disease process before they manifest symptomatically so that we can actually change the trajectory of their disease. And this is one of the most powerful things that we do as a clinician. I like to call this proactive medicine rather than reactive medicine. So let's talk a little bit today about stages A and stages B of heart failure and how we can prevent them. So stage A is basically when a person is at high risk for heart failure, but has not yet developed symptoms and has not yet developed any structural abnormalities. So this is someone warning you that they're headed towards that heart failure destination, and it's time for you to sort of help them wake up and clean up their act. So as a preventive cardiologist, this is a place that I really love to see my patients at because I feel like I can start to make an impact, educate them about their disease process, and really help them to change that. So let's talk about, for example, the patient has hypertension. We know that hypertensive heart disease, where the muscle burns out after a while, is a big cause of structural abnormalities, including LVH, atrial dilation, as well as reduction in ejection fraction. So aggressive management of hypertension, both with diet and lifestyle, as well as with medications, is really important. The other thing, of course, is things like smoking. So the mnemonic that I like to use that often sticks with my patients is the ABCDs of heart failure prevention. So A stands for activity. We want to encourage our patients to get at least 30 minutes of moderate intensity exercise every single day, but at least 5 times a week, because we know that it releases chemicals, helps with endothelial function, and it really does help improve heart and vascular health to the point where it can really have a dramatic benefit on incident heart failure. B stands for that blood pressure. You really want to target that early, target that aggressively, screen patients for hypertension, of course, and if they develop it, make sure that you're maintaining that goal, which for most of our patients is going to be less than 130/80. C stands for cholesterol. If somebody has high LDL, you know that the natural history of that disease is going to be deposition of that LDL in the endothelium and subsequent inflammation. So you really want to try to target that early to reduce their lifetime risk. I have patients, for example, who are in their 30s and 40s who I am placing on LDL lowering therapy because I don't want them in their 50s and 60s to start to have coronary events or start to have, coronary artery disease. And C also stands for cigarettes. So if somebody smokes, you got to get them off of those cigarettes. And then D, I like to say, stands for diabetes. And so, if somebody has diabetes, they're at very high risk for developing structural abnormalities, developing vascular disease. So these are patients that you want to manage aggressively. Now, in the ACC/AHA heart failure guidelines, they say that patients with diabetes who are at stage A don't yet have disease, don't yet have symptoms, should be treated with SGLT2 inhibitors because that signal has emerged with that class of medications actually reducing risk of incident heart failure in our diabetic patients. So we're starting to learn about catching the disease early with the ABCDs of prevention. We also have risk estimators, just like with coronary disease. So, when you're trying to think about somebody's risk when it comes to developing blockages, you put all their numbers into something called a pooled cohort risk estimator. With heart failure, you have a pooled cohort heart failure estimator, and that is something you could potentially use in certain individuals to try to estimate their lifetime risk. Now, of course, don't forget to ask them about family history, because we know that some percentage of cardiomyopathies are actually going to be inherited. So I like to call that the ABCDs of cardiovascular prevention for stage A. Now let's talk about stage B. because that's when that warning that their disease is giving you just got a little bit louder, because they're almost ready to progress to stage C. So the difference between stage A and stage B is that they actually have structural abnormalities in stage B. Structural abnormalities can look like left ventricular hypertrophy, they can look like atrial dilation, they can look like LV dilation, they can look like valvular heart disease. So this is basically the heart has started to feel the effects, whether it's their risk factors or whether it's their valvular heart disease or whatever their risks are for incident heart failure, but the heart has started to manifest those changes structurally. Now, they don't yet have symptoms in stage B, and that's the distinction between stage B and stage C, where they end up having symptoms. But really, our goal as clinicians is to prevent them from ever progressing to stage C. And the nice thing about heart failure is that it follows a nice, reliable trajectory. So we know that those progressions are going to occur A to B to C to D, and we really want to try to catch them as early as possible and modify their risk as much as possible. So when it comes to managing our patients with stage B heart failure, what we recommend, of course, is most of the things I talked about in stage A also apply to stage B. But on top of that, I would layer on additional things. So I would say you want to make sure that they're vaccinated. Keeping their vaccinations up to date can reduce their risk of incident heart disease. If they have a reduction in their ejection fraction, there are a few medications that you should be reaching for. And these are particularly ones that are going to change adverse ventricular remodeling. So if that heart pump is already looking like it's gotten weak, whether that's because of a heart attack or because of high blood pressure, or valvular heart disease, or what have you, you want to rest that heart muscle as much as possible. You want to interrupt those neurohormonal signals. How do you rest a muscle that's beating all the time? Well, you give it medications like beta blockers, which reduce the neurohormonal activation. They reduce our sympathetic nervous system, so the heart's not working harder and faster. You give it medications like ACE inhibitors, which prevent the renin-angiotensin-aldosterone system. They reduce adverse remodeling, reduce the fibrosis. They can help with inflammation as well. You, of course, want to continue to treat whatever that underlying problem is, whether it's coronary disease, valvular heart disease, hypertension. Treat those aggressively with medications like statins and antihypertensives and other lipid-lowering therapies, because at this point, again, the heart has already started to feel the effects, whatever that insult is to the heart muscle. This is also in stage B where I start to think about biomarkers. Now, sometimes I do think about biomarkers in stage A as well, especially if they're particularly high risk. I might get a screening NT-proBNP or proBNP, which are the natriuretic peptides. But once they've actually started dilating their atria, or dilating their ventricle, or starting to have LVH, you know that the intracardiac pressures are affected. And so those markers of stretch, like the natriuretic peptides, can start to go up. And that can be another way in which the disease warns us about what's about to happen, because those markers go up, and we know that that happens before the clinical event happens, before the patient gets edema, before they start getting short of breath. So that's really something you want to think about checking as well, because if those markers are elevated in stage B, then you really want to be even more aggressive about starting some of the additional heart failure medications. Now, we know that in stage C, there are 4 pillars of management: beta blockers, for sympathetic nervous system blockade; ACE, ARBs, or ARNIs for RAS system blockade; mineralocorticoid receptor antagonists for blocking the RAS system as well. And then the newest marker is the SGLT2 inhibitor. But if your patient is an advanced stage B, you maybe want to start to think about some of those interventions as well. So, the nice thing about heart failure, it's one of my favorite diseases to treat, in fact, because it's reliable. It responds very well to therapy. And I know that if I am doing the right things by my patient, introducing them to all these medications, educating them about the importance of compliance, about risk factor management, and about prevention, I can make a tremendous impact on their morbidity, their mortality, their prognosis. And sometimes we even see that reverse ventricular remodeling. So you can see stage B actually go back to stage A, which means that their ventricle, their EF recovered, their heart is structurally normal. That is one of the most rewarding things, I will say, in clinical practice. I'm thrilled that as a preventive cardiologist in 2023, we are at the stage where we have so many tools in our toolbox, not just for coronary artery disease, but now really to start to think about other conditions like congestive heart failure, think about their pathophysiology, and really try to interrupt that process early, aggressively through education, through interventions, through risk prediction. Certainly, the ACC AHA guidelines have really put their nickel down on the importance of thinking about stage A and B, not just waiting for stage C to start to think about some of these guideline directed medical therapies and some of these interventions. Thank you so much for your attention.